So thank you everyone for the opportunity today. So just really quickly, I'm going to be ambulatory focused in this talk. Obviously there are analogies across the continuum of care, but there's a lot of work happening in ambulatory right now in this space. It's about a 10,000 foot view, not 50,000, not right on the ground, given the complexities and the many variations on this theme. And these are my own views. So is anyone listening? And the idea here is wonderful work by Kristinsky and her team looking at how much time providers actually spend in the room with a patient, only about half their time. And among that, only half of that in-room time is spent actually interacting with the patient. The other half is spent with our heads buried in the EMR and doing administrative work. Then also some interesting work from Tally Holman at the AAFP and folks at Wisconsin, looking at the complexity of ambulatory visits. This on the right up here, you can see this, what happens in an ambulatory visit suddenly becomes very complex about the sorts of things that can happen, the order in which they happen, and the fact that these are usually quite iterative and it doesn't actually have a standard beginning, middle, or end, that people tend to jump around all over the place. And each one of these cut points represents not just an interruption in your interactions with the patient or within your work in the EMR, but it's a cognitive break and an opportunity for error. So I want to talk a little bit about some of the strategies that are being employed currently for team-based documentation. Obviously, we have the lone wolf, which is the current status quo, and then but then we have these other strategies such as the Sidekick. That's primarily using scribes, although with recent CMS rules can include students. And then what I call Teamlets, and these are small teams that will go work with an individual provider and follow the patient from within the room throughout their entire care, sort of in a navigator role as the provider goes from room to room. And there are nursing models for this, there are LPN and medical assistant models, and in other specialties there are models as well, including things like athletic trainers for orthopedics and technicians for ophthalmology. So just to look at the sort of status quo, I think we're all sadly aware of this. The lone wolf model is heavily dependent on the provider to do the vast majority of the clinical documentation. This schematic just shows us sort of a standard visit from the waiting room to the rooming process, with then the provider in the room with the patient, then the post-exam activities, check out with receptionists, and then on the far right, this big area of activity that includes the in-basket work, which is now one of the biggest drivers of burnout in ambulatory settings, as well as pre-visit preparation for the next visit. So this Sidekick approach is typically with scribes, although as I mentioned, students can play a role here too. And really this person acts as a shadow. They follow the physician or the provider from room to room. It's typically a 1-to-1 ratio. And they're really limited in their scope in terms of what they can do. They're really there just to do documentation. They don't really have any clinical role. One of the benefits of this approach, in addition to taking some of the benefit off the documentation burden off the providers, is that it really requires pretty minimal disruption in workflow and EMR design. But you don't really get much added benefit or added value due to their limited clinical role, and the in-between visit work is really untouched. So Teamlets, here you can see the color palette has changed much more dramatically here with the support team. And as I mentioned, they tend to stay with the patient in a navigator role as the provider works with them in parallel, usually in multiple exam rooms, which brings some efficiency to the practice. And they bring much more added value through increased scope of practice, doing things like in-basket help, doing actually a fair amount of what the clinician was doing in the lone wolf model. And the clinician activity is really now in the exam room is focused directly on the patient with minimal time with their head in the electronic record. And most of their time with the record is typically verifying, editing, and approving the things that are entered by other people. You'll notice in this schematic that the checkout desk is now gone because the navigator will typically do that with the patient, including scheduling their next appointment. And then the other huge benefit here is that those support team members can be used to dramatically reduce the amount of work that the provider needs to do in between visits for the patient. So, so that, for example, MAs can scrub in baskets, call patients back, get clarifications and, on their questions, and so on, and even participate in pre-visit planning. One of our pilots, we actually had the front desk sending new patient questionnaires out to patients and getting those results entered into the electronic medical record. So a lot more value added here, but also you can see is going to be pretty disruptive to the way that you practice. Lastly is this team of teams approach. As we've already mentioned, having patients, family, and caregivers participate in this. Some institutions have centralized services that participate in things like triage, refills, prior authorization, so on. And this is a pretty diverse set of strategies depending on what's available at your organization. So there is some evidence of benefit in these from these approaches. Particularly with scribing and the Teamlet models, we see evidence of charting time and after-hours documentation improving, up to 50% reduction in burnout rates, increased provider satisfaction up to 10 times, better long-term retention of providers and staff after the original disruptions, better quality access relationships. Typically, RVUs or dollars per visit or per hour are increased in these models, and that's used to cover the increased cost of the staffing to support them. So some key lessons and costs and concerns. You know, none of these approaches are magic or automatic. They all require some degree of training, EMR build, there's a learning curve, and often a lot of disruption and early turnover with the Teamlet models. Even with scribes, you know, you have to train these people to your own particular way of practicing. There sometimes can be space and capital improvement requirements, and sometimes individual autonomy can be threatened by some standardization of workflows that's required for effective, efficient Teamlet work. These are all beholden to market forces, the 3 Ws, what's happening with wages and workforce in your market, as well as winnowing, the idea that if organizations are having budgetary constraints, usually the first thing they do is cut staff. There are issues with creeping scope of practice, either up or down, that need to be managed. And then, as we mentioned before in both sessions here, variable regulations and interpretation. So what these staff can do in their scope of practice is, can be variable based on state laws, whether you have unions in your state. What does your Medicare administrative contractor, your MAC, have to say locally? That can vary by region. And then, as we've mentioned before, organizational compliance leadership and whether or not you're on the Joint Commission may influence the success of your work. And then there's some lingering concerns here around privacy, accuracy, and safety. That's much less well studied than the other outcomes I've mentioned. And really, I think the two big problems here is that this isn't reducing documentation, it's just shifting it onto other care team members. And that actually may be actually enabling these outdated regulatory compliance ecosystems that we live in, and also enabling underinvesting in IT rather than promoting some of the things we've heard about earlier in the session today. Lastly, about COVID-19, there's some questions about this at the first session last week. One of the issues is these staff are disproportionately women and minorities. They're essential workers, and therefore they're at increased risk for severe disease and infection. Also, they tend to be primary caregivers at home and have a tendency to have to drop out from the care team because of that. You end up with reduced staffing, which then erodes capacity and morale through quarantine, infection, redeployment to the inpatient setting or testing centers, and furloughs. And then that reliance on fee-for-service and volume dependence, as the volumes were dropping across the country in ambulatory, revenue went down, which led to decreased staffing and increasing burnout. On the positive side, though, particularly with the Teamlet model, with the advanced teams and the added value they bring, you have a really deep bench to reach into when emergencies like the pandemic hit. And the practices that succeed at this, someone mentioned change management earlier in the chat, and I think they really become change management experts in order to make this work. And these teams tend to be really resilient, adaptive, and work well together once these particularly the teamlet approaches are up and functioning, and tend to have a we're in it together